So, good afternoon, all. You are welcome again in our oncology educational courses. So, on behalf of Professor Fadi Farahat, the president of CRG, Cancer Research Clinic, and myself, we are welcoming you in our educational course of today, which will be updates in non-colorectal cancers. Our activity, as all of you know, it's endorsed by ASCO and UICC and awarded by 2 CMEs from EMAC. The activity is translated to French, so you can hear it in French. We will start with Professor Fadi Farahat with a quiz on hepatocellular carcinoma. So, Dr. Farahat, the floor is yours.
Thank you very much. I will start by sharing my slides. So
now we have the quiz in hepatocellular, Dr. Fadi.
Yes. Can I share my slides, please? Participant can now see the screen.
Yeah, we are waiting. We have now 101 participants hearing us in our educational course.
So I skip the first question. Here we have some cases. Please, you have to interact with us. We have a patient, man, 62 years old. Dr. Mustafa Tahfi said that we have more men than women. Came to the clinic with the history of self-administered tattoos. He saw on television about HCV and did the test, and he's positive. So he went and did screening MRI. On MRI, we have splenomegaly, hepatic nodularity consistent with liver cirrhosis, 2.6 centimeter lesion in right lobe of liver that showed rapid arterial enhancement with significant washout on delayed images, which is typical to the HCC. So a patient's self-discovery of HCV and MRI, we have element of in favor of HCC with liver cirrhosis and 26 millimeter lesion. What further testing should be done in order to make the diagnosis of HCC? Should we do a biopsy, alpha-fetoprotein? If normal, proceed to biopsy. Should we do tumor markers, CA-CA19-9? No further testing or a CT scan, ultrasound to explore more the vascular characteristics. So please vote. What should we do after? So indeed, no further testing is the right answer. Now, you know very well that for a hepatocellular carcinoma, it's maybe the only one, or maybe with the choriocarcinoma, 2 diseases where we maybe do not need a pathology to treat patients. So any patients with typical imaging and sometimes high alpha-fetoprotein might go for treatment without doing a biopsy. So theoretically, we do not need a biopsy for the hepatocellular carcinoma if the imaging is typical. Second, alpha-fetoprotein first, if normal, proceed to biopsy. We do alpha-fetoprotein in general, and it helps us to control the disease and not to treat, not to diagnose. So it's not diagnostic marker, it's for follow-up. A tumor marker CA-CA19-9, we can find in some cases really elevated tumor marker, but it's not needed. And the CT scan in the presence of MRI with a typical features of washout on delayed images is not needed. So the right answer is no further testing. When you have an imaging with an evident in good hand with an evident diagnosis of HCC, we don't need further treatment. So any comments from the audience or from the speakers, from the colleagues? Okay. No comments. We can ask later. So the next question is about the management of large solitary HCC. 32-year-old woman recently immigrated from infected with HPV region. Upon evaluation for a job, she showed abnormal liver transaminase and she did imaging, 6 centimeter well circumscribed lesion within the left lobe, vascular characteristic consistent with HCC, no element of cirrhosis. The proteins in bilirubin, albumin, platelets, and INR are normal, alpha feto very high, and the CT show no other lesions. So what we have, alpha fetoprotein and a 6 centimeter well circumscribed lesion in the left lobe, typical for HCC, and no liver cirrhosis in a young patient, 32 years. What would be the next step? Should we do a biopsy, evaluation for potential transplantation, follow up the lesion to determine the rate of growth, immediate resection if feasible, chemoembolization, or local treatment to reduce the size followed by resection? So is it surgery? Is it a biopsy for diagnosis? Is it transplantation? Or simply follow up? Please submit your answer. It's tricky, but like just to... So let's check the answers. We have a biopsy of the lesion. We don't need it, as we said. Full evaluation for potential transplantation might be an option if it's non-resecable. Follow the lesion. We will not, because the lesion is there. We have to decide, since we can probably cure the patient. Immediate resection when feasible is the right answer, and I see that 42% went for that. Chemoembolization, it's not the right indication. Usually we do it if the tumor is not resecable. Local treatment to the mass, you mean by that chemoembolization or radiofrequency or cryotherapy? We don't use cryotherapy in such cases. Radiofrequency we should have a small lesion. So again, there is no need for biopsy. The diagnosis is clear. No transplantation since the patient is operable. No follow-up because we have to make a decision and go for treatment, and maybe curative treatment, which will be the resection. So the resection is really the indication in such cases. And here I can show that the curative treatment in non-cirrhotic patients is the ideal. And remember, 32 years old, non-cirrhotic, high alpha fetoprotein, 6 millimeter. So yes, it's the treatment of choice for her. The next question is about a multifocal. We had unifocal, now multifocal HCC, 59 years old man, history of alcohol abuse, quit drinking 11 years ago, presents with hematemesis, bleeding from the esophageal varices, ascites, splenomegaly, and low platelets count. MRI, 2 lesions about from 2 to 3 centimeter in right lobe. And there is a peripheral enhancement on the arterial and delayed phase with central washout and peripheral enhancement. Okay, and the imaging again shows a splenomegaly, ascites, and varices. Once treated, stabilized, and discharged, further, we mean once treated for his hematemesis, okay, stabilized and discharged, further management should include which of the following? Should we send him for donor transplantation? Should we do a hepatobiliary surgery for potential right hepatectomy, chemoembolization, thermal or cryoablation for the 2 lesions, PET scan to look for metastatic lesions, systemic treatment with sorafenib? It's a tricky. Remember, we have we have a small perigastric varices, and we have also ascites. What's your answer? Please submit. So I see that the questions here are really, the answers are all over the, we have unequal responses. I remember in the previous slide and the previous case, and maybe it's good to go back to show it. The transplant is good because it might cure the cirrhosis with HCC. Okay, so it might be one of the options for this patients. Dr. Mustafa, are you still with us? I don't think so. Concerning the ablation, I don't think it's efficacious in such cases, but we might argue that either we go for transplantation because we have liver cirrhosis and we have the same time the HCC. If not, probably the treatment should be systematic with the first line. It was Sorafenib or bevacizumab plus atezolizumab. Okay, now we have a case of 71-year-old man, no symptoms, history of hemochromatosis. In a workup, the gastro found 7 centimeter mass in the right lobe consistent with HCC. He is not a surgical candidate, which means the ideal here was the surgery. In such case, again, the ideal was the surgery. He is not a surgical candidate because he has cardiovascular disease. But the liver function, again, are normal. What do you suggest for this patient? Is it radiofrequency ablation? It's only one lesion. Is it stereotaxic body radiotherapy? Is it chemoembolization? Is it liver transplantation? Or is it Sorafenib? So is it local treatment with radiofrequency stereotactic body radiotherapy, chemoembolization, or is it transplantation, or is it medical, the Sorafenib? Please submit your answers. Yani I have a 100% right responses, guys. So chemoembolization or radioembolization, stereotactic body radiotherapy, radiofrequency. So mainly we are voting for chemoembolization, while the answer here is a stereotactic body radiotherapy. Why? Radiofrequency in such indication is not acceptable. We already said that usually up to 3 centimeters we can use it. Sorafenib is not the case because we still have options for local treatment. So we'll not go for a general treatment, medical treatment, if we have the option to treat locally. Liver transplantation, it's also not the case because there is a place for local treatment. So the ideal here is to do surgery. It's not operable, so we go for the local treatment, which ideally is a stereotactic body radiotherapy here because the mass is huge and the liver is still functioning well. Chemoembolization, I think it's not really the ideal indication if we have the possibility of a stereotactic body radiotherapy. And believe me that even I missed this answer because we are not really, we don't use frequently the radiotherapy. Okay, another patient with a PMH significant only for diabetes, present with back pain, and has a lytic lesion T11, multiple metastases in the liver, in the lungs, and a bone metastasis. Liver biopsy demonstrated well-differentiated hepatocellular, and the patient desires systemic therapy. So polymetastatic to the bone, to the lung, HCC. Okay, What will you suggest? Gemcitabine plus cisplatin or oxaliplatin, nivo-capecitabine, sorafenib, or best supportive care? Can you vote, please? Okay, sorafenib 60%. Okay, very well. I think it's the right answer. The SHARP trial showed that this was the real and the first line treatment as showed by our colleague. So I will stop here, if you don't mind, to go to the next presentation. Dr. Sami Al-Khatib, the floor is yours. If there's any question, please share it with us. I see there's no question, and I'm happy we are at 106 participants. Thank you really all for your active participation. Please, Dr. Sami, the floor is yours.
So let me present Dr. Mustafa Tuhfe, who is going to talk about the recent advances in hepatocellular carcinoma. Dr. Tuhfe is Associate Professor at Hematology Oncology Department, University of Montreal Hospital Center, Canada. So Dr. Mustafa, the floor is yours. Our audience, we have an excellent number of audience now. We have 88 participants from all over MENA area. So welcome to all to be with us. Dear Mustafa, the floor is yours.
Thank you. I'll try to share my presentation. Okay. I'm sorry because we have some issues with Zoom in the hospital. I just see. Actually, thank you for the invitation. I hope I will be able to do it and to share with you these slides. And sorry again, because my camera is not functioning with Zoom. We moved to Teams here in Canada. So thank you, Dr. Khatib, for this kind presentation. And I'm glad to share with you that I've been ranked to full-time professor early last week. So these are my conflict of interests. And I'm going to review with you the new advances in the management of advanced stage hepatocellular carcinoma. As you well know that HCC is the 5th most common cancer worldwide, 2nd most common cause of cancer deaths with a male predominance. And the incidence is increasing worldwide in the USA and in other countries. And we historically know that the incidence is increasing. The HCC is seen because of viral hepatitis, because of alcohol consumption and alcoholic cirrhosis. But we are seeing more and more of NASH steatohepatitis or non-alcoholic steatohepatitis leading to cirrhosis, mainly because of obesity and overweight. So this is a brief summary of how usually we look for the different stages to simplify the management and the treatment of HCC. So for early stages with localized nodules, surgery is the main treatment. It could be a simple resection, it could be a hepatectomy, a transplant, or ablation with a stereotactic radiotherapy. For intermediate BCLC, the Barcelona classification B, usually we go for local regional treatment, TACE or TARE. For patients unsuitable for local regional treatment or those who show progression, we go for systemic therapy, and we are going to review together the systemic therapy. Unfortunately, there are always patients unsuitable for any treatment because of high Child-Pugh score or for a bad ECOG. And for these patients, we go for palliative care and supportive care. So historically, we saw the CHART trial, which was the first treatment approved for HCC for locally advanced progressive after local treatment and metastatic disease. Patients were randomized between the placebo arm, which was considered as the standard at that time, and Sorafenib. And Sorafenib showed an improvement of the median overall survival, 10.7 versus almost 8 months, with a hazard ratio of 0.69. This was published more than 12 years ago in New England. And we saw an improvement of the survival in the Asian population also. So since 2008, Sorafenib was considered the standard for mainly child A patient with a BCLC B and C stage. Then came the REFLECT trial with lenvatinib, another oral tyrosine kinase inhibitor, compared to Sorafenib, which was considered the standard in unresectable HCC. And in REFLECT trial, we also had patients with child score A, BCLC stage B and C. Almost 1,000 patients participated to the trial, patient with a good ECOG, and some of these patients had a major vascular invasion with portal invasion. So it was a non-inferiority trial, showing that lenvatinib is as equal to Sorafenib in terms of overall survival and progression-free survival. So the lenvatinib showed a median survival of 13.6 versus 12.3 for Sorafenib. And these two molecules became the standard. The choice between them was a matter of toxicity profile. Both of them cause hypertension, more hand and foot syndrome with Sorafenib. We saw the Checkmate 040 trial presented by Antonelli Khwairi a few years ago, also at ASCO, and published in Lancet, which was a phase 1/2 trial of NIVOLUMAB in patients with HCC child A and B7, so high B7, good performance status, patients treated or not with Sorafenib. And you see patient tolerated or no the Sorafenib, patient progressing without viral hepatitis or having hepatitis B or C. They were showing around 20% overall response rate. All these trials were done before the EMBRAVE 150, which was presented a couple of years ago and published in 2020 in New England. So I was saying that EMBRAVE 150, the first trial combining an anti-PD-L1 with an anti-angiogenic, the bevacizumab. We've saw in earlier trial that this combination was promising with an overall response rate of 36%. And we all know that anti-angiogenic agents have shown some benefit for the treatment of HCC. So patients with locally advanced and metastatic or unresectable HCC with a child PUA and ECOG 0 or 1. So the patients were randomized with a 2:1 in the Sorafenib arm for the standard arm and for the atezolizumab bevacizumab combination as the experimental arm. Treatment until PD or toxicity. And as you see, 40% of the patient had microvascular invasion with 50% hepatic involvement or main portal vein invasion or invasion of the portal vein branch. But patients who had uncontrollable varices or bleeding were not allowed and were excluded from the trial. So the trial was positive for its co-primary objectives, the overall survival and the PFS, and we saw an improvement in the survival of the in the OS, 12 months, 67% for the combination arm versus 56% for the standard arm, the Sorafenib, and the median improved by almost 6 months, with a hazard ratio of 0.66 and a significant p-value. We saw also an improvement in the PFS. And this led to establish the combination atezolizumab, bevacizumab as a standard for the HCC, child view, BCLC, and B good performance status. If there is no contraindication to both of them, autoimmune disease or any major bleeding problems for the bevacizumab. The update response showed also an improved response rate in favor of the combination arm. And the median duration of response was 18 months versus almost 15 months for the combination versus sorafenib respectively. What about the safety? Nothing new. We saw more hypertension, more diarrhea, more end-head food syndrome in the sorafenib, but we saw more upper GI bleeding rate with the combination of atezo with bev versus sorafenib. The time to deterioration was improved with the combination arm. So this became the other first-line therapy with immunotherapy was the checkmate 459 for nivolumab versus sorafenib in first line. Again, sorafenib as a standard arm with the nivolumab at the experimental arm and patient child score A, good ECOG, unresectable. And the primary objective was the overall survival. The hazard ratio threshold for them was established for 0.84. And if you see that there was an improvement of the overall survival in favor of the nivolumab, but this was not statistically significant. And the hazard ratio previously established for 8.4 was 8.85 in the trial. This led to the NCCN guidelines 1 year ago, going for the combination of atezo-bev as a standard for a patient with this child A good performance status, and the other recommended regimen if there is any contraindication, sorafenib or lenvatinib. Nivolumab could be used, but if the patient, unless the patient has a really contraindication to anti-angiogenic agent. Also, the results didn't show a major improvement in the survival compared to other anti-angiogenic agents, the oral TKIs, sorafenib and lenvatinib. And this year, our friend Ghassan Abu Alfa presented at ASCO GI 2-3 months ago the Himalaya trial, the combination of dual immunotherapy, durvalumab with tremelimumab versus sorafenib as a first line. We've seen in previous phase 1-2 trials a signal and the potential benefit of this combination. So patient, again, unresectable, no prior systemic treatment, BCLC, B. So I've been saying that patient with a good performance status, BCLC stage B and C, child score A, were randomized between 3 arms. So the dual immunotherapy, durvalumab alone, or sorafenib. And we've seen the results of primary endpoint OS for the dual immunotherapy versus sorafenib. So the trial was positive, showed an improved OS for durva-tremi versus sorafenib with a median survival improved by almost 3 months, 16.4 versus 13.8, 22% less risk of mortality with a significant p-value. And when we looked for the OS subgroup analysis, we showed that the benefit was seen in all subgroups. Maybe it was less important for female patients and for patients with HCV hepatitis. What about the objective response rate? The objective response rate was 20% for the durva-tremi combination, and the time to response was a little bit more than 2 months in the immuno arm versus almost 4 months for the sorafenib arm. And the last trial I'm presenting for the first line was presented last ESMO. It's the COSMIC 312. cabozantinib with or without atezo versus sorafenib. Same population, PCLC B or C, unresectable, no prior systemic treatment. Child A scored good ECOG, and patients were randomized between the combination arm, sorafenib, the standard arm, or cabo monotherapy. The primary endpoints were the PFS for the combination arm versus sorafenib and the OS for the intention to treat population. The patient showed an improvement of the PFS for the combination arm 6.8 versus 4.2 with a hazard ratio of 0.63. But if you see the results concerning the OS, there was no difference between the combination arm and sorafenib. So this is for the first line. What about the second line? It's a rapid review of what we know and what we knew from the previous studies. We have 3 studies: the RESOURCE, Celestial, and REACH2. RESOURCE with regorafenib versus placebo. These patients showed progression after sorafenib in first line and were eligible for second line. So here these patients were randomized between regorafenib and placebo. In Celestial trial, cabozantinib versus placebo, and in REACH2, ramucirumab versus placebo. For those who remember, REACH1 was a trial randomizing patients ramucirumab versus placebo, but the subgroup analysis showed that only patients with alpha-fetoprotein more than 400 showed an improvement. So this is why FDA asked to have a REACH2, another trial, the REACH2 trial for this subgroup of patients. All these trials showed an improvement of the OS. And if you look for the placebo arm, we had the same population. The survival for the placebo arm was almost the same, 8 months, 8 months, and 7.3 months. So we can say maybe we were treating the same population. I think we were treating the same population. And the median OS for the experimental arm, regorafenib, cabozantinib, and I was saying the median OS for the experimental arm, regorafenib, cabozantinib, and ramucirumab was somewhere between 8.5 and 10 months. And one of these was approved and considered as an option for second-line treatment after sorafenib failure. What about the side effects? We didn't see any unexpected side effects. We have hand and foot syndrome more with regorafenib and cabozantinib. No hand and foot syndrome with REACH, with ramucirumab. But we had hypertension and more risk of bleeding with the ramucirumab. What about the usage of lenvatinib and sorafenib after atezo and bev? Because most of us are using atezo-bev as a first line. We don't have true trials asking and trying to define the best option as a second line, but we have retrospective analysis showing that lenvatinib and sorafenib both can be used as second line after failing atezo and beva. And in these retrospective trials, we saw a little bit improvement of the PFS in favor of the lenvatinib. But when it comes for the overall survival, we didn't see any difference, no statistically different median OS between these two options. Another trial for second line, the KEYNOTE-240 with pembrolizumab. Patients progressing after sorafenib, always in a good performance status, child A, stage B, C, randomized between placebo or pembro, with the co-primary endpoints, PFS and OS. We saw an improvement of the OS in favor of the pembrolizumab, 13.9 versus 10.6, and an improvement also for the PFS, which is less important. The difference was less important than we see with the OS. Checkmate 040, combination of dual immunotherapy in second line. We don't have a lot of data. This was an abstract presented last year showing an improvement in favor mainly of the Nivo 1 and EP3 milligram, but the toxicity was much higher in favor seen in this arm. So this is why NCC and last year recommended regorafenib, cabozantinib, ramucirumab, lenvatinib, or sorafenib after failure of immunotherapy in second line. Other options were nivolumab, ipi, or pembrolizumab. But if you see, these are category 2B. So not a lot of evidence supporting these options. At least here in Canada, we don't have access to nivo, ipi, or pembro in second line after failure of sorafenib or lenvatinib in first line. So you all know and see already this algorithm. So depending if it is an early stage, as I've mentioned, so surgery, ablation, or transplant. For intermediate BCLC B or C, we can go for local treatment if we can. If no, we go for advanced for systemic treatment. Dual treatment with immuno and anti-angiogenic now is the standard. And if there is any contraindication, we can discuss with the patient the option of immunotherapy, monotherapy alone. What after the first line treatment? So if you start with atezolizumab, regorafenib, cabozantinib, maybe an option. Sorafenib and lenvatinib also are options, but we don't have a lot of data. These are based on retrospective and expert opinion. If you start with sorafenib and lenvatinib as first line, you can go with regorafenib, cabozantinib, or ramucirumab in second line. Nivo, pembro, not a lot of evidence. And these options should be discussed usually in tumor board. We have to discuss them, at least in my hospital, in tumor board, before being accepted as an option in second. I don't have, if I have few minutes, I'm sorry with the problems I had, just to tell you what about the child B and C score. Not a lot of that. We do know that patients with a child score B and C behave badly, and we don't have a lot of trials accepting these patients. We have some evidence with child B, mainly in sorafenib, and the high child B, the low child B, the child B7, and this was not based on high evidence. And this is a checkmate 040 for nivolumab. We saw that we may have some response for child B patients, and but we have to be cautious with these data. This is a small group of patients, and usually patients who participate in clinical trial, they behave very well. They don't really reflect what we see in our real-world experience. In my humble experience, the child B patients, they do not behave well, and they have less response, less tolerance, with more side effects than patients with child A, even if they have a good ECOG. I think this is my last slide. I'm really sorry. I just learned that the hospital is not supporting any more Zoom. So next time, Fadi, I'll bring my laptop.
No problem. Thank you very much. First of all, again, congratulations for your new title, full-time professor. And thank you for accepting our invitations. And thank you for having problem in internet. This made us somehow relax. It doesn't happen only in our countries. So guys, we are happy for that. And we open the floor for the question. And since we are with Dr. Sami moderating, there is a nice question. Can we use ipilimumab instead of tremelimumab with durva in countries that didn't have treme? Both are CTLA4 inhibitors. What do you think? Can we substitute?
We don't. We show the combination. We see the combination in second line. We don't have evidence for first line. Can we extrapolate, or can we have to, or we are allowed to substitute? I don't know. if you look for other tumoral sites, we didn't see that the combination durva-tremi showed a benefit like nivo-epi in lung, in colon. So I'm not sure. I won't go for a substitution, honestly. And here in Canada and Quebec, in my institution, it's not allowed. There is no evidence to support, although we know that both of them are anti-CTLA-4.
Okay, another question. According to NCCN, we need MSI high to use dostarlimab as second line for treatment of HCC. Why they request this test on subsequent line when while it's omitted for the first line? Okay.
I honestly, when I reviewed the subject and I saw this recommendation, I asked myself the same question. I totally agree with the colleague who asked the question that MSI testing is now becoming a standard for every GI tumor. And we're doing it frontline upper diagnosis. For MSI high patient, I agree we have to go up front with an anti-PD-1 treatment. Pembrolizumab is accepted here in my institution. We have to discuss it. We have a committee. We have to discuss the case in the tumor board, presenting the case to the committee. But when it is MSI high, when whatever is the GI site, the treatment is accepted. And I really agree that we have to move it to the first line. And I'm not sure that a combination of dual immunotherapy is better than one than anti-PD-1 alone as a first line.
Okay. I think we have another question from Asma Bahauddin in the chat box. She's asking, can we use the Pembro after failure of Sorafenib as second line?
Yes, this is one of the keynote trial. I think the keynote 240 showed that pembrolizumab is an option. The data is not mature. We didn't have a lot of evidence, but it is acceptable. If you have access, if you don't have a committee in your hospital looking for all the details, I think this is a good option, yes.
Any other question for Dr. Mustafa?
Then thank you very much, Dr. Mustafa, for the presentation.
Thank you. At least my Zoom didn't cut during the question.
Yeah.
Even though we could follow you very well. Thank you.
Thank you. Thank you very much.
Okay, so it's a kind of a small reminder. We know very well that gastric is frequent. We will have some questions that might be as an introduction to the presentation of our friend, Professor. First question, which therapy option is the only one with the potential for cure in gastric cancer? Chemotherapy, surgery, radiotherapy, combination therapy. Please, you can vote in order to have some the answer is combination therapy and not surgery. Here it's a typo mistake. As it was answered by the majority, the treatment is combination therapy. You know very well that we have a neoadjuvant therapy approved. Nevertheless, in a quiz, a similar quiz done earlier in Europe, the questions were 50-50 surgery and combination therapy. But the right answer is a combination therapy and not surgery. Okay. The second question, which factors does the surgical approach to gastric cancer depend? It's somehow tricky. What are the factors that will impact the decision for surgery in gastric cancer? Is it the type and degree of symptoms? Is it the diagnostic testing? It's the location, size, invasion characteristic of the tumor, or is it the stage of the disease? Please answer. So again, really, félicitations. Again, the right answer is the location, size, and locally invasive characteristic of the tumor. And we did here, like it was done in previous international quiz. Yes, it's the right answer, number C. So the next slide will be the type of surgery performed for located the tumor in cardia or around the gastroesophageal junction. It's somehow easy as a question. What type of surgery do we perform when we have a tumor of the cardia? Is it total gastrectomy? It's perigastric lymphadenectomy, subtotal gastrectomy, or esophagogastrectomy? Please vote. So right answer, the right one is the following, esogastrectomy. And if we look to the guidelines, the NCCN recommends D2 dissection over D1 dissection. And we have to remember that a larger D2 lymphadenectomy provides greater staging information. So that's the reason. And remember, the total gastrectomy is performed if it is required for negative margins, which mean the subtotal gastrectomy is really required when we have a distal stomach, and we perform total gastrectomy when the tumor is big and we need negative margin. So next question, according to NCCN guidelines, what's the treatment option for potentially resecable CT1B gastric cancer? So is it the endoscopic resection or surgery, perioperative chemotherapy with surgery, systemic therapy, palliative management with chemoradiation? Which one? Again, it's a potentially resecable T1B. So the right answer is endoscopic mucosal resection. And also we can have both answers as it was in previous. But since the tumor is really small, I think we do not need chemotherapy in the CT1B. Dr. Mustafa, can you comment? Do you want to comment on this slide? Do we need to go for preoperative chemotherapy, perioperative chemotherapy in such cases?
No, I'm sorry, I had some issues with the Zoom platform in the hospital, so I couldn't put my camera. But I'm okay with the answer. We have to go for an endoscopic mucosal resection. It's an early stage T, and we don't need any pre or post-op treatment. Pre and post-op treatment are usually given for T3 and above, or for node-positive tumors.
Okay, we both agree on that. If there is no comment, we'll move further. This is the rationale, by the way. If anyone wish to have the presentation, you can ask our host, Sciences Pro. So the next question, according to ESMO guidelines, which regimen is recommended as first-line therapy for stage 1B or higher HER2-negative resecable gastric cancer? So what's your frontline treatment in HER2-negative gastric cancer? Is it platinum with fluoropyrimidine? Is it topoisomerase 1 and taxane? We mean by that taxane. Is it platinum plus anti-HER2 tumor cell? Or is it triplet therapy like FOLFIRINOX? So is it cisplatin 5-FU or cisplatin capecitabine? Is it taxane, Is it anti-HER2 platinum-based chemotherapy or triplet therapy? First line, front line. Okay, again, platinum and fluoropyrimidine combination is the treatment of choice. So which one? The platinum and fluoropyrimidine combination is the treatment of choice. And there is a rationale for that. You know that there is the European with docetaxel and other drugs, while in USA we are more doing platinum and 5-FU. With that, I will stop.
It's really a pleasure to present my friend, Dr. Hampin Khoury, who is going to talk about the role of checkpoints inhibitors in the management of gastric cancer. Dr. Khoury is Assistant Professor, Hematology Oncology, Department of Faculty of Medicine, St. Joseph University, Beirut, Lebanon. Dr. Khoury, the floor is yours.
Thank you, Professor Khatib. Also, thank you for Professor Farhat for inviting me and giving me the opportunity to present in the next 20 to 30 minutes the role of checkpoint inhibitors in the management of gastric cancer. So my presentation will start with an introduction, then I will discuss the chemo-refractory gastric cancer studies based on immune checkpoint inhibitors, then the first line advanced gastric cancer studies, the HER2 positive, and finally the take-home messages. So it's interesting to see that according to Globocam 2018, that the gastric cancer represent 5.7% of all cancers worldwide, and the mortality rate is 8.2. So those cancers are still very aggressive and killing a lot of people. So it's really an unmet need, and the management of this kind of tumor necessitate to introduce new treatment option for our patients. So in this review paper, where we tried in our university to describe the incidence of gastric cancer in the MENA region, clearly we can see that in some countries like Oman and Yemen, we have really high incidence of gastric cancer, while in the Levant in Egypt, it's a little bit less, and we have an intermediate incidence rate in Morocco and Algeria. So, as I mentioned, the gastric cancer is becoming an important public health problem in our region. Second, we have a tsunami of biomarkers that are necessary to guide the management of this type of malignancy. So today, we should do the HER2 and the MSI at the diagnosis of the advanced gastroesophageal adenocarcinoma. Also, the PD-L1 is sometimes necessary, the tumor mutational burden, and also the NTRK, that is an agnostic biomarkers in all tumor. So as I said, we had an unmet need. The chemotherapy alone was not really the drug that changed the natural history of this disease. Or we had some anti-angiogenic agents that were approved, but with the tsunami of immune checkpoint inhibitors starting 2015, things were changing. And these new medications were necessary to change the history of gastric cancer as they change the history of different diseases like melanoma, like lung cancer, and urothelial cancer. So in the first part of my presentation, I will be developing 3 trials that evaluate the immune checkpoint inhibitors in gastric cancer in chemo-refractory population, the Attraction 02, Keynote 051, and Javelin 300. So let's start with the Attraction 02, which evaluated the nivolumab in chemo-refractory gastric cancer. In this trial, patients with unresectable, advanced or recurrent gastric or gastroesophageal junction cancer who received 2 or more regimens with good ECOG performance status were randomized 2-to-1 to nivolumab versus placebo, with the primary endpoint was the overall survival. And we can see here that we have very interesting results, very good response rate and duration of response, as you can see, but also nivolumab had reduced by 38% the risk of death compared to best supportive care. So really interesting agent in chemo-refractory advanced gastroesophageal carcinoma. And you can see here that independent of PD-L1 status, we had an advantage of nivolumab versus placebo. We have a clear separation of curves. What about the median overall survival was considered more than 2 years in third-line population, and this was really a very interesting finding. The second trial that I will discuss is the Keynote-059, where pembrolizumab was evaluated in patients with the same population, 2 lines or more of pembrolizumab, and we have also very interesting results with 12.6% of overall response rate. We have a comparable efficacy with the previous trial. The Keynote-059 showed also an important duration of response, mainly in patients with positive PD-L1, and you can see clearly that patients having PD-L1 positivity had better disease control rate and overall response rate. The avelumab, another immune checkpoint inhibitors in Javelin 300, also in patients who received 2 or more previous treatment, didn't show any benefit in overall survival. So the first 2 drugs showed positive results, the pembrolizumab and the nivolumab, in chemo-refractory gastric cancer. However, the avelumab didn't show this benefit. And we can see here that the PFS benefit favors chemotherapy. So take-home message in chemo-refractory gastric cancer: anti-PD-1 therapy is superior to best supportive care in patients with chemo-refractory gastric cancer. And in the Javelin 300, it was not superior, the avelumab, to chemotherapy in chemo-refractory gastric cancer. The second part of my presentation will discuss the first-line advanced gastric cancer studies. And here it's important, as I mentioned, the role of biomarkers in evaluating the treatment plan. So when you have a diagnosis of advanced gastric cancer, it's important to have the HER2 status at the beginning to see how we should manage those patients. And we have 2 new standards of care where immune checkpoint inhibitors were included in the armamentarium of the treatment of these drugs in HER2 negative patients and HER2 positive patients. So in Checkmate 649 study, which is an important and pivotal study who led to the approval of the new standard of care in HER2 negative advanced gastric cancer, combining nivolumab plus Xelox or nivolumab plus FOLFOX. The eligibility criteria in this study was previously untreated first line unresectable advance of metastatic gastric cancer. ECOG performance status was good, and we have 3-arm studies. Now I will develop the 2 arms where we have randomization 1-to-1 between Nivo plus Xelox or Nivo plus Folfox compared to Xelox and Folfox only, with the primary endpoint being overall survival and PFS. And the PD-L1 for the primary endpoint was in patients with PD-L1 having CPS more or equal to 5. And this is important to be discussed. Why? Because the first approval was based with the primary endpoint regarding the PD-L1, and we have in mind that maybe this drug is only approved in this population. However, we had an extended approval, and I will discuss it later, in all comers independently of the PD-L1 status. And you can see that in the secondary endpoint, we have all randomized patient overall survival and patients with PD-L1 more than 1 and more than 10. So the baseline characteristics of the patients were really well balanced between Nivo plus chemo versus chemo alone regarding the age, the sex, the region, the Asian and non-Asian. The 3/4 of the participants in the study were non-Asian. Also, the location of the tumor was really well balanced, the PD-L1 status, the presence or not of peritoneal metastases, and finally the MSI status. Regarding the primary endpoint, we can see here that the overall survival and progression-free survival was really positive in all randomized patients. We have an advantage of around 2.2 months Nivo plus chemo versus chemo in all randomized patients. And we can see that at 2 years, 28% of patients who received Nivo plus chemo were still alive compared to the 19% in chemotherapy arm alone. And also we have an advantage in progression-free survival and clear separations of curve. So we have meaningful improvement in overall survival and PFS with Nivo plus chemo versus chemo alone, and this was maintained for as longer follow-up. Also, when we want to see in the subgroup analysis regarding the primary tumor, the region, the age, the sex, the PD-L1 status, the location of metastasis, we have overall survival favored Nivo plus chemo versus chemo across key subgroups in all randomized patients. Also, we can see here clearly that the efficacy in the subgroup analysis by PD-L1 status was really interesting. We can see that in all the subgroups, independently of the PD-L1 status, patients had very interesting results. And what is also important to say that when we have higher PD-L1, maybe we have better overall survival and objective response. However, all the patients will benefit from the addition of nivolumab to chemotherapy independent of the PD-L1 status. And also we can see here that overall response rate was higher and responses were more durable with Nivo plus chemo versus chemo, regardless of PD-L1 status, if it's more than 5 or less than 5. As I mentioned, the primary endpoint was the population with CPS more or equal to 5. However, when we see all this data showing that we don't have difference on PD-L1 status and the outcomes of those patients, so this has become a standard of care in all patients independently of the PD-L1 status. Also, we have best percentage reduction in tumor burden was more deep in patients receiving Nivo plus chemo versus chemo alone. And this is also an interesting endpoint. What about the treatment-related adverse event when adding Nivo to chemo versus chemo alone? We didn't find any new safety signals by adding this immune checkpoint inhibitors to chemotherapy, and it was really well tolerated. And the main side effects were related to chemotherapy and mainly the hematologic toxicity of the chemotherapy, the FOLFOX, without having major toxicities by adding nivolumab. And it's important to say that in the Nivo plus chemo arm, as in all immune checkpoint inhibitors, we had immune-related adverse event, mainly the endocrine, the gastrointestinal, hepatic, pulmonary, renal, skin. And now we are more and more aware about this type of toxicity, and consequently, we are more able to manage the toxicity, and we know that the percentage is really small. Consequently, our patients will not present many side effects. So the conclusion of the authors of the study, Nivo plus chemo continued to demonstrate clinically meaningful improvement in efficacy versus chemo with an acceptable safety profile with longer follow-up in previously untreated patients with advanced gastric cancer. Also, the overall survival benefit across key subgroup and enriched at higher PD-L1 CPS cutoff. We have more deep and more durable response regardless of the PD-L1 status, higher overall response rate across all evaluated PD-L1 CPS subgroup, and also OS and ORR benefit across PD-L1 CPS subgroups. So this one was the pivotal trial that led to the approval of new standard of care in the first-line advanced gastric cancer. Another trial with a parallel design tried also the KEYNOTE-062 to compare pembrolizumab with or without chemotherapy versus chemotherapy in advanced gastric adenocarcinoma. And we can see here the design of the trial: locally advanced, unresectable or metastatic gastric or gastroesophageal adenocarcinoma, HER2 negative, ECOG 0 or 1. And you can see that we had a randomization in 3 arms: pembrolizumab monotherapy, pembrolizumab plus chemo, or chemotherapy alone. The primary endpoint was overall survival and PFS. So when we compared the pembrolizumab to chemotherapy in this population, we can see clearly that we have a crossing of the 2 curves without a clear advantage of pembrolizumab. So we had similar results. What about adding pembro to chemo versus chemo? Also, we can see here we didn't have a clear advantage or significant advantage. We have the interval of confidence 0.7 to 1.03, and we can see here that in the subpopulation of CPS more or equal to 1, we didn't have a benefit of adding pembrolizumab to chemotherapy, and also it was the same in the subpopulation of CPS more or equal to 10. So the take-home message from the advanced gastric cancer, HER2 negative, in the first line was that Nivo and chemotherapy is the standard of care in first-line advanced gastric adenocarcinoma. Pembrolizumab alone is not inferior to chemotherapy in PD-L1 positive gastric cancer, and pembro plus chemo is not superior to chemotherapy alone in PD-L1 more than 1 or 10 in advanced gastric cancer. So the only study that showed the advantage of adding immune checkpoint to chemotherapy was the NIVOLUMAB study and become the standard of care. In the HER2 positive population, we have also a new standard of care, the Keynote 811, and here we had a histologically or cytologically confirmed diagnosis of previously untreated, locally advanced or unresectable or metastatic HER2 positive population. And the randomization was 1-to-1, pembro, trastuzumab, chemotherapy versus trastuzumab, and chemotherapy was considered for a long time the standard of care. And we can see here that we have very interesting result, and it was presented by Yelena Janjikian, and in this trial by adding pembrolizumab, we have better overall response rate. When we added to trastuzumab and chemotherapy, 74% of overall response rate versus only 51%. And this is really interesting results. You can see the difference of response rate by adding immune checkpoint inhibitors pembrolizumab to chemo plus trastuzumab in HER2 positive advanced gastric cancer, and the FDA grants an accelerated approval to pembrolizumab for HER2 positive gastric cancer. Also, things are really moving in a very fast way. We have 2 approvals in the advanced stage in refractory chemo-refractory gastric cancer. In the first line, we have the approval of nivolumab plus chemo in first line HER2 negative, the pembro, trastuzumab, and chemo in the first line HER2 positive, but also in earlier stage in gastric cancer, we have the integration in many ongoing trials, the immune checkpoint inhibitors, as the Keynote 585, where we had the perioperative chemotherapy plus or minus pembrolizumab, the Attraction 5 in patients who had resected gastrectomy, adjuvant chemo, plus nivolumab, it was only in Asian patients. And we have also trials trying to add atezolizumab plus perioperative chemotherapy, and also durvalumab in perioperative chemotherapy. So immune checkpoint inhibitors are going earlier and earlier, as we are seeing in lung cancer, in urothelial cancer, in renal cancer, where these new drugs are being used as earlier as possible. So as a summary, this is a very interesting slide that will summarize the importance of immune checkpoint inhibitors in the management of gastric cancer in the advanced setting. So we can see in the first line, we divided the gastric cancer in HER2 positive and HER2 negative. In HER2 positive, chemo, trastuzumab plus pembrolizumab become the standard of care. In HER2 negative, independently of CPS, the standard of care become chemo plus nivolumab. In TMB high and MSI high, the pembrolizumab in second line is approved as, and those 2 biomarkers are agnostic biomarkers. And also we had the nivolumab in advanced gastric chemo-refractory, where nivolumab also showed very interesting results. Thank you, and I'm ready for your questions.
Thank you very much, Dr. Hampik. We have 2 questions for the time being. The first is, which test is essential in advanced gastric or GEG cancer to give immunotherapy? So what's the preferred test to go for immunotherapy?
As I mentioned, in the advanced stage today, we can give the standard of care independently of the PD-L1 status. And this was really approved. We should do the HER2, which is necessary to choose the right immune checkpoint inhibitors, plus to add the trastuzumab if it's HER2 positive. But in the early or in the first line setting of advanced gastric cancer, today doing PD-L1 is not really necessary. But in patients who did not receive the immune checkpoint inhibitors in the first line, PD-L1 will be interesting to be used to say if our patients will benefit from nivolumab or pembrolizumab in the third line or the second line setting. But also the MSI is an interesting biomarker to be done, because we know that this combination may not be approved in many countries for the moment, but in MSI positive patient, maybe in second line setting, pembrolizumab can be administered. So in practice, what we are doing in first line setting patient, to know if those patients will really benefit from chemo-immuno, the PD-L1 might be interesting. You should do the HER2 and you should do the MSI at the diagnosis.
Okay, so if we can, recapitulative, we start by doing HER2 positive. HER2, if it's negative, if it's positive, we treat anti-HER2 with chemo and probably with pembro. If it's negative, we can do the CPS. Okay, but if you can even skip it, since it's approved for every patient, nivolumab with chemotherapy. But just if you do it in order to see if you have other options. This one. Second, in your second line, you can do pembrolizumab. But do you need to do a PD-L1 testing for pembrolizumab in second line? Do we need it for approval or it's all comers? Pembro.
So the MSI, we can do it in second line to give and the TMB, but the PD-L1 for second line and more is important to give the nivolumab and to give the pembrolizumab in patients who didn't receive immune checkpoint inhibitors in the first line.
Okay, it's clear. Now another question, which chemotherapy preferred in combination with nivolumab? In other terms, is there any other chemotherapy than that used in the checkmate? Any combination?
You have the two options. You can use the FOLFOX and you can use the Xelox as backbone chemotherapy in this trial. So you have the two options, and the two chemotherapy were really well balanced between the two arms. So it depends on the preference of the patient. As we know, in some countries or some institutions, they will prefer to give the Xelox. In France, for example, they will prefer to give the FOLFOX as a backbone regimen. So both are possible treatments.
Okay, so I think for asthma, Bahauddin, it's clear. So the treatment should be used, the nivolumab should be used as per protocol, FOLFOX or Capeox. So another interesting treatment question for you, Dr. Hampi. Is there any study about HER2 mutation, not overexpression?
Till now, we don't have a clear evaluation of anti-HER2 in this subgroup of population. Honestly, we don't have this data for the moment.
So if you allow me to explain a bit, in HER2, what we see usually in breast cancer is overexpression. It's not like in EGFR or others mutation type, it's overexpression. So when we have even in breast an overexpression, we treat with anti-HER2. When we have a mutation, we don't know what's really the efficacy of the anti-HER2. So in gastric cancer, probably it will be the same as in breast cancer. We do not have any trials since the mutation for HER2 is very rare. Okay, now there is a request from Dr. Bensal Asia.
Our friend from Algeria, she is Professor Asia bin Saleh.
Yeah. Okay, Professor Asia is asking if there is any ongoing trial that the Department of Constantine might participate in. So it's a request for all of us, since they have, yeah.
Maybe for Hamping, Asia, she is a full professor and the head of the Department of Oncology at Constantine University in Algeria. So Asia, always you are welcome, and any trials that we will have, you will be the first that we will let you know.
For sure.
So Dr. Sami created recently in the AMAC a section for research. But we have to say, I would like to answer Professor Asia. You know very well that the trials, pardon, we have either phase 2 trials, investigation-initiated trial, and for the time being, we are not running such trials, or we have the international. Unfortunately, the international will not depend on us. It will depend on your pharma in Algeria. So they have to put Algeria on the map for research, and they have to communicate and contact the pharma. That's what we do usually. But for the investigation-initiated trial, we as a cancer research group, and Dr. Hampik is part of this group, we published many trials at a time with phase 2, and we had only one experience regional with Syria. So maybe for the future, we have to work on that. And I think Dr. Sami Al-Khatib, it's your role to push يعني pour ça لحتى تدفع بهالاتجاه. What do you think, Dr. Sami?
Yeah, inshallah, as you know, we created the group. Regarding other groups, there are some trials in phase 3 is going on in cervix and endometrial cancer. So I will let you know, and will let Dr. Asia know about it if she is interested to be in. Inshallah, we'll do it very soon, and we'll push it with all this excellent group that we have all together.
Okay.
Also, Professor Khatib, I will suggest to do research by subspecialty also. It will be interesting, for example, to have a group for GI oncology, also to try to join forces from the region to develop in each category clinical trials, and to send proposal to see how we can collaborate together. Because I think the future for our region, and we can do it, we have the patients, we have the institution, is to collaborate together. Because everyone, if he will work alone, we will not have so much input.
So inshallah, it's a good suggestion, and really, as you are doing now, that you are mainly interested in GI. So we'll let know all our colleagues in the area and Algeria. They have a huge potential of patients, so will be involved in all our trials. So thank you, Dr. Asia, for being with us and for giving us these suggestions. If you allow me just to announce that our next activity will be next Tuesday, May 24th, and it will be in breast cancer. So you are all welcome. We are happy that we have 102 participants till now with us, and Prof. Fadi, the floor is yours.
Thank you very much. First of all, I would like to say that from Kirkuk, also they are interested in trials. I think everywhere there will be interest if we do it correctly. So thank you very much. Thank you, Dr. Hampik. Thank you, Dr. Sami. Thank you, Dr. Mustafa Tahfe, for your participation. Thank you, Sciences Pro, Vanessa, specifically for your work. And big thanks for the audience. Really, we are till now at 101 participants, which is excellent. And I would like to emphasize on the fact that if you have any idea, if you wish to participate as a speaker, as moderator, panelist, chairman, anything, please contact us. We do not know all your specialties and subspecialties and interests.